Welcome to A New Prescription, where we explore modern healthcare, cutting-edge medical research and technology, and the complexities of healthcare politics. Join us as we provide insights and solutions to help you navigate the American healthcare system. Welcome back to A New Prescription, the podcast where we help you navigate the American healthcare system. I'm your co-host, Leonard Zwelling. And with me, of course, is the purveyor of truth. I know him as Dad, but he's Dr. Leonard Zwelling. Dad, we're now on video, so say hello to the people.
Hi, people. Today's topic is how to be not just a better patient, but a more effective patient. It has to do a lot with communication on your part, on listening carefully to the doctor, and making sure that that communication line is open all the time, if possible. You're trying to develop a relationship with this other person who is going to care for you.
So, Dad, can you frame up for us, what does it mean to be a good patient and why is it so important?
Well, I think there's two problems that are fairly unique today. The doctor basically has less time to spend with each patient. Unfortunately, there's a great deal of corporatization in American medicine. Many doctors are employees of large conglomerates that are often privately owned by private equity with shareholders and stock value. And in a lot of ways, those companies are trying to maximize their income, maximize the value of their shares. And that's done in the clinic by having doctors see more and more patients. Thus, each doctor has less time to spend with each patient. So patients have to use that time efficiently. Even though the doctor may want to spend more time, they don't always have it. So that is the biggest problem that patients are facing today. The kind of casualness and slowness that used to be the case in patient visits is not the case any longer.
So why is it so important, though, to be a good patient other than what we've talked about in our previous episodes of the system is just broken right now and moving very quickly to see you?
So in essence, you have to be a better communication of your signs and symptoms for the doctor to be able to make the diagnosis and come up with a treatment plan, knowing that both you and the doctor have less time to do it. So you have to communicate as accurately as possible. You basically have to become a great storyteller and a great advocate. You have to tell your story and be an advocate for your own health. Not that that wasn't always the case. It's just more important now than ever.
I really think there's an important point to underscore with a story that I've recently went through. My wife and I just moved to Austin about 5 months ago. And about 3 months ago, she really started having these debilitating headaches. We had to go to the ER a couple times. We weren't really sure of what was going on. We thought it was sinus related. So the first thing we did after the ER visits was go to an ENT. Now, Dad, I have to tell you, that ENT visit here was very underwhelming. We didn't really get any explanation as to what was going on, what could be the cause, and she didn't have any relief for her symptoms coming out of that.
So the fact that there wasn't a resolution and a diagnosis, there needs to be at the end of that visit a plan of how you would get to that diagnosis. Okay, it's okay not to have an absolute diagnosis in the first 15 minutes. It's not okay to not make a plan of what you're going to do to get to that diagnosis. Now, what did you do to finally get to that diagnosis? How did you manage to do it?
Well, I've had a lot of practice in the Zwelling household being the son of two physicians. I did not take the visit as our final stop. I just wasn't satisfied with what was going on. So I actually called an allergist that I knew in Houston. If Dr. Colaco is listening, thank you so much. we went to Dr. Colaco and he immediately did an infection test in her nose. And we found that she had a sinus infection, which was the cause of the headaches. Now, she since has had symptoms come back. So we're looking more deeply at if there's more to this that's going on. But we were able to initially relieve some of the symptoms and get a relief from not having to go to the ER all the time.
Well, I think the story here focuses on two pieces. First piece, you've got a diagnosis because in a very low-tech way, Dr. Colasso was able to make the diagnosis. So one of the issues is, why didn't the ENT doctor do that? It's fairly straightforward. You just take a swab of the nose, put it on a slide, stain it, and look for bacteria. The problem is, I believe, that a lot of the younger physicians, and I know this will offend some of the younger physicians, but they tend to depend on technology. That doctor probably would have gotten a CT scan of her sinuses before he just took a simple swab of her nose. Colasso, although he's fairly young, is a very old school physician. He really does all the things I used to do when I was a younger doctor, with a physical exam and a careful history, and then does the appropriate laboratory test. That's the first part. You had a diagnosis. Second part, the diagnosis was correct, but it did not resolve the long-term problem. Now there's a plan of what to do going forward. It might necessitate more invasive treatment, but there's a plan. You know what you're going to do. So one of the things in being a good patient is pushing for a diagnosis, knowing what the plan is, knowing what to expect from that plan, whatever the treatment is, knowing when that plan is failing, and when the plan is failing, knowing what to do next, all of which you did.
I want to take a step back on the diagnosis piece that you mentioned. What can a patient do to make sure they're really getting the right diagnosis and getting the answers they need on that first, second, and third visit when they're doing initial consultations and trying to figure out what's wrong with them?
Yeah, it's pretty hard because most patients don't go to medical school. Because one of the tricks is that you need to have some idea of what's going on. And if you really had a great idea of what's going on, you may not have to go to the doctor. You're going to the doctor for his or her expertise. And that involves making a definitive diagnosis, or at least having a differential diagnosis, a list of what the possible causes are and how you will rule in or rule out any one of those diagnoses. That is basic medicine. The differential diagnosis is the essence of diagnostic medicine.
So for those listeners who are plain simpletons like me, what the hell is a differential diagnosis?
It basically is saying the doctor has collected a history, and remember, about 80% of the diagnoses can be made from the history alone. So it's important for the patient to be a good storyteller and the doctor to be a good listener. Then there ought to be a good physical exam, the appropriate laboratory test. And when all those data are accrued, you then come up with a list of possible causes for the disease. That's the differential diagnosis. And then there needs to be a plan to rule in or rule out anything on that list. That is basic internal medicine.
So is it safe to say a good rule of thumb for those patients that are not physicians, they should come out of those initial visits, not with just a diagnosis, but a list of what could actually be causing the issues as a good next step to move forward to the plan?
Yeah, I mean, the doctor should want that. The doctor should want a good differential diagnosis, that list that we talked about, and then a good plan of perhaps imaging studies or laboratory tests to determine which of the differential diagnosis list is the most likely cause of the problem. Because if you can localize which of the problems is most likely, you will come up with the best treatment plan. because that's, after all, what we're going for. You're trying to treat that patient and make the patient better. So the patient needs to be, like I said, the patient needs to be a good storyteller and a good advocate. The doctor needs to be a good listener, and together they need to come up with a plan to go through the differential diagnosis and decide what the most likely cause of the problem is.
So I'm going to have you go back into the memory bank. When did you have a patient that was a really good patient where you were able to do a differential diagnosis effectively and were able to treat their symptoms?
Actually, a fair number of the patients that were presented to me when I was taking care of patients were like that. I can think of one patient that I was taking care of at the National Cancer Institute, already had the diagnosis of lymphoma, which is a lymph gland malignancy.
Okay.
He had been treated effectively and his disease was in remission. And he came back to see me feeling lousy. He just felt lousy. So I went and said, okay, this is what could cause you feeling lousy. Of course, the number one concern was his tumor was back. But we did all those tests to look for the tumor and it wasn't there. So I put on my thinking cap and wrote down the possibilities. What could be wrong with him? I did a bunch of different tests, and it turned out he had something pretty unusual called apathetic hyperthyroidism, where his thyroid gland was overactive, but it made him feel lousy. Usually those people are hyperactive and bouncing off the walls, but in this particular case, it was the actual opposite. That's the name of it. That's why it's called apathetic hyperthyroidism. And we were able to treat him and he felt better. So that was a clear example of listening to the patient, doing the appropriate tests, writing down a differential diagnosis, and coming up with a fairly rare explanation for what was going on.
And were there specific things that he was telling you that really helped you put this puzzle together?
Yeah. I mean, his complaints were completely systemic. He had no focal pain. He had nothing that specifically pointed to a specific part of his body. And perhaps most importantly, his symptoms then were not the same as his symptoms when he presented with lymphoma, which were carefully described in the medical record. So although it could have been lymphoma coming back, his lymphoma didn't present like this. So I had to keep looking.
So the key is the patient was able to effectively tell you what was going on with him and what his symptoms felt like when you came into the room.
Yeah, he also was a very, very smart and very good patient. He also had one other asset that I think don't want to miss. His wife was a terrific advocate for him. She was every bit as good at describing what was going on as he was. So he not only was a good advocate for himself, he had another advocate in the room who was pushing me to figure out what was going wrong. And she was pretty convinced this wasn't the same thing all over again.
So having an advocate with you to listen to the doctor and help you navigate is really an important part of the diagnostic piece and getting better.
Very much so. And by the way, before you go to the doctor, if you have an advocate that goes with you, you could practice your story on the advocate and try to get that as good as you can get that script down pat. I have 15 minutes. I've got to explain my story in 5. So he has 5 minutes to examine me and we have 5 minutes to discuss what we're going to do next. It's unfortunate, but 15 minutes may be all you get.
So we've talked about the diagnosis piece. I want to get to the second piece. You talked about the plan of moving forward. Sometimes, how do we know if we're going with the right plan as a patient? And how do we trust it? Because sometimes there's some patients out there that don't trust to move forward with the plan that's put in front of them. How do they make those decisions?
The trust part really comes through the relationship with the caregiver and the patient. There's no shortcut to trust. That just is something that has to develop. And it's very difficult to do that in the first visit. That's for sure. The second piece is when you have a plan, there ought to be a time frame with an expectation of when you should get better so that you can come back if you don't. An example would be I'm having, as you know, a whole series of back problems. And I just saw the doctor last week, and we have a plan going forward for a new problem in my neck. And I know that if 6 weeks of physical therapy doesn't make it better, there is a next step that I can pursue with him. So there's a definitive plan with a specific timeline, not a bad thing to have.
How do we go through that, both differential diagnosis and then executing on a plan with patients who are either very sick with very serious illnesses, or even potentially a loved one and you're trying to manage someone with end of life?
Two different questions. As far as someone who's acutely ill, let's say on a cardiac care unit or an intensive care unit, the differential diagnosis is exactly the same. I mean, the process is the same. And very often you have somebody who, let's say, came in with a heart attack and was severely ill, a little bit of cardiac failure, perhaps not breathing well. Doctors decide to take him to the cardiac care unit to make sure things are going well. And then things start not going well. His heart gets worse. Then you're still there with the differential diagnosis. We had this, we thought that things are not going well. Why not? What are the possibilities? It's still a differential diagnosis. You still rule in or rule out things, and then you intervene when it becomes clear what the problem is.
When we get to those situations that are seriously critical, what can our viewers think about as patients to get through this very tumultuous time, to continue to be a good patient for the doctor?
I think the most important thing there is family and advocacy, and having someone in the bedside who knows your wishes and understands why you're sick. We haven't talked about advanced directives, but the idea of having someone go through the thought processes of what he or she might want done. If they're severely ill, do they want to be intubated? Do they want to be resuscitated? That's something to think about before you're sick, and to write that down in an advanced directive and make sure your doctor has a copy of that advanced directive. That's certainly an important part of self-advocacy, really.
Let's say someone has cancer. What about those more long-term illnesses like cancer? How can someone be a great patient when all of this tumultuous stuff is they're going through right now?
Yeah, that's a matter of understanding your disease. Usually by the time you're in that setting, the patient's diagnosis is clear. The amount of patient education materials, both on the internet and in most hospitals for cancer patients, is tremendous. There is no reason not to educate yourself fully on what your disease is, what to expect, what are the consequences of therapy. All of that is available, and all of it should be taken up by patients and read and understood, for sure.
So can you go through an example when you were a doctor and you were helping a patient get through a very tumultuous time?
Yeah. I mean, I did that when I was young, and I must admit, I don't think I was great at it. It is very traumatic when a patient has a serious illness. You've done everything you can to make that patient better, and it's not working anymore.
Is there any specific patients you remember? Like any specific stories you can think
There's
about?
one in particular, there was a young breast cancer patient who had a very aggressive form disease, and it actually metastasized to her spinal collat. Now, she actually had malignant cells in her cerebral spinal fluid, and the fluid that bathes the brain. And we had to treat her for that. And she had young children and a very concerned young husband. And it was obviously very traumatic for them. And it was very difficult for me because I hadn't had enough experience at dealing with that. There's one thing that's for sure the case when it comes to people with cancer. Older cancer doctors are far more adept at handling this than some of us young ones were, I must admit. And one of the things I think I did on a regular basis is ask for help from the senior attending physicians. I mean, the patient was devastated at each turn. I mean, she certainly saw the handwriting on the wall that this disease was going to be her undoing. She knew it. All you can do is try to talk to the patient. I can remember so many patients like this, and each of each patient, as you might imagine, is different. Some people are extremely stoic, and some people just break up completely and are not really prepared to handle this. A lot of it depends on their caregiver or their spouse as to be supportive. And in these patients we were just talking about who are unlikely to be cured, then one of the things an adept doctor can do is begin to recruit the helper, the caregiver, into going along with the plan. Because the plan may be at some point in the future to stop therapy. That could be the plan. And that's a painful plan, but it's not uncommon. And more importantly, going over that plan with the patient in advance of getting to that point. The idea is you must encourage hope. You've got to encourage hope, but you also have to bring in reality. And at some point, sometimes the hope seems to evaporate. And trying to be supportive in that situation is extremely difficult for the advocate with the patient and for the doctor. It's tough. It's very difficult.
Yeah, those are very difficult times, both for the patient and their families. So if there are listeners out there who are going through this, just know that our hearts and prayers go out to you. So to sum it all up, there's really two parts getting in and going and seeing the doctor. There's the differential diagnosis, and then there's a plan to execute moving forward. And you have to advocate for yourself on both parts. And that's, be prepared, ask questions, push for answers, seek a second opinion, and advocate for yourself. And whatever that looks like, that can look different in different situations, whether you have an advanced directive or a loved one with you when you're going through this together.
Yeah, I mean, my view has always been that you should teach kids in high school how to be good patients. I mean, it should be part of the curriculum. Before you get older and before you get sicker, it's best to know what these things are ahead of time. And if high school is supposed to prepare you for life, it ought to be in high school.
Well, Dad, this has, of course, been very informative. I think you've given us a lot to think about of how to be a good patient in this healthcare system that seems broken, inefficient, and downright frustrating. Are there any last words you'd like to give us before we send it off?
Take a deep breath, slow down, and listen to what the doctor has to say before you jump in with another 6 symptoms that you discovered on the internet.
And that's the final word. We hope that this session has empowered you to take control of your healthcare journey. And until next time, please join us on our social pages on Facebook, LinkedIn, Instagram, and TikTok. Our handle is @ANewPrescription. You can also see videos on YouTube. Our handle is @ANewPrescription YouTube. And remember, take care of yourself. Your health matters the most. We'll see you next time.